Next, we'll move on to the obstructive lung diseases. So what are the various obstructive lung diseases which we know of? Chronic bronchitis, and then emphysema, which together is called as the COPD, which is chronic obstructive pulmonary disease. Other than that, we have bronchial asthma and bronchiectasis. These four are usually called as the obstructive lung diseases. So first we'll see about COPD, which is a constellation of both chronic bronchitis and emphysema. So in chronic bronchitis, what we are going to have, there will be airway destruction. Same for emphysema. Along with that, there will be inflammation of the small airways. Along with, there will be inflammation and destruction of the lung alveoli. So that was what happens in the emphysema. So both of this condition have a very, very strong association with smoking. So let's first see about chronic bronchitis. In chronic bronchitis, it is classically defined as production of copious sputum, that is sputum along with cough, for continuously 3 months in 2 consecutive years. And most important thing is, the other causes of this copious sputum production should be ruled out. So this is the classical definition of chronic bronchitis. It is going to be associated with smoking. And what happens is that tobacco smoke contains various noxious substances. So these noxious substances are going to go and irritate the epithelium. So bronchial epithelium is going to be irritated and damaged. So as a response to this irritation, the epithelium will start producing more mucus. So we all know bronchus is also going to have mucus glands in the submucosa and then cartilage also. So the submucosal gland layer, it is going to produce lots of mucus production as a reaction to this irritation. So this increased mucus production, what happens is, it cannot be cleared out so easily by the ciliary function. So when this mucus is there, it itself serves as a fertile soil for various infective organisms to grow. So there is an increased risk of infection associated with chronic bronchitis, especially with Haemophilus influenza. And when infections come, that again is going to cause irritation, and that will again lead to the increased mucus production. So this goes on like a cycle. And the very important point to remember about chronic bronchitis is the Reed index will be increased. So what is Reed index? Normally, the mucus gland layer thickness divided by the entire wall thickness, that is from the epithelium to the cartilage. The entire wall thickness is that epithelium to the cartilage. Okay. So divided by this will be normally 0.4. But here what did we see? In chronic bronchitis, the mucus gland is going to undergo hypertrophy. So that layer is going to get thickened. So that divided by the entire wall thickness is going to be increased in chronic bronchitis. That is what is called as Reed index is increased in chronic bronchitis. So that is a very important question. Remember that. So how will the clinically the patients present with? These patients are usually called as blue bloaters. Why? Because I mentioned there was increased mucus production, right? So when this mucus production was there, this is the alveoli, and we are having this increased mucus which is lining this. So this is the bronchial epithelium, if I am telling, and you are having this increased mucus production. So what is happening is there is decrease in the ability of the oxygen to diffuse through it. So oxygen diffusion is going to be reduced, and the patient is going to experience hypoxia, and because of that cyanosis also. So when the patients are undergoing cyanosis, they'll be appearing blue in color, and they'll have a very pursed lip breathing. That is, it will be difficult for them to breathe, and they'll breathe like this. Okay. And here the patient can also undergo pulmonary hypertension, and that will result in right heart failure or cor pulmonale. Complications of chronic bronchitis is, since it is going to irritate the bronchial epithelium, the bronchial epithelium can, which being the pseudostratified ciliated columnar epithelium, can undergo metaplasia into a squamous epithelium, and then it can undergo dysplasia and also cancerous. It can turn into cancerous. Okay. And the one thing it is important to remember about chronic bronchitis is it is going to be never associated with amyloidosis. Usually amyloidosis is associated with chronic inflammatory conditions, right? So SAA protein, serum amyloid associated protein, is going to form the AA amyloid, and that is going to be associated with any chronic inflammation. But this chronic bronchitis is not going to be associated with amyloidosis, but it can lead to cancer. Okay, remember that. Next is the second part of the COPD, which is emphysema. So in emphysema, what happens is that there is going to be destruction of the wall which is distal to the terminal bronchioles. So what part is it which is distal to the terminal bronchiole? Obviously, it includes the acines, that is respiratory bronchioles, alveolar ducts, and the alveoli. So this forms the acini, right? So this part is going to be dilated and destroyed. The wall of the acinus is going to be destroyed. So what is the most common cause associated with emphysema is again smoking only. Other than that, it can also be associated with alpha-1 antitrypsin deficiency. So what actually happens in this condition is, in smoke, it can increase the protease activity. So smoke is going to irritate the endothelium, we already saw. So neutrophils will be recruited, and when neutrophils are recruited, one of the enzymes present in neutrophils will be elastase. So it is a protease. Elastase is a protease enzyme which is going to damage the elastin present on the alveolar wall. So elastin is the one which is responsible for the elastic recoil of the, for the expansion and shrinkage of this lung alveoli. So this is going to be lost when this elastin is going to be damaged, right? So smoking recruits inflammatory cells which is going to produce these elastases, and this elastase will in turn damage the elastin of the alveolar wall, resulting in the damage of the alveolar wall. Okay. Also, in alpha-1 antitrypsin, so alpha-1 antitrypsin is actually a antiprotease. Okay. Alpha-1 antitrypsin is an antiprotease which will normally sequester this protease enzymes like elastase and degrade them. But in alpha-1 antitrypsin deficiency disease, this antiprotease is not going to be there. So there is going to be uncontrolled elastase activity which is going to cause the alveolar wall damage. So the most important thing to remember about emphysema is there is alveolar wall damage into the acinus here. Next, we'll see about the types of emphysema. So first type will be the centri-acinar type. Centri-acinar in the sense, here the as part of the acinus which is being involved will be the respiratory bronchioles. So this part, so this is the respiratory bronchiole, and the cloud-like part will be the acinus I have represented. So this respiratory bronchiole is being involved while the alveoli is spared in a centri-acinar type. And this type is going to be the most common one which is associated with smoking. And anywhere smoking related injury is there, it will usually affect the upper lobe, because smoke is a gaseous substance. So gas usually tends to move up. So always smoking related diseases will be associated with upper lobe. Okay. Next, we'll see about the next type of emphysema, which is pan-acinar emphysema. So as the name suggests, it is a pan type of thing. So both the respiratory bronchiole and the alveoli is going to be involved in pan-acinar type. And this is the type which is going to be associated with alpha-1 antitrypsin deficiency, and here it is going to be common in the lower lobes. Distal acinar or the septal type of emphysema is the one in which the distal part, that is the alveolar part, is going to be involved while the respiratory bronchiole is being spared over here. And here it is going to be associated with spontaneous pneumothorax, because this is the distalmost part, right, alveoli. So when this wall of the alveoli is being destroyed with the emphysematous process, so what will happen? Air will leak out, and that will cause spontaneous pneumothorax, and it is a very emergency kind of condition. Okay. Next, the last type of emphysema will be irregular emphysema. It doesn't follow any pattern. Irregularly, it is going to involve the respiratory alveoli, respiratory bronchiole or alveoli. So this is the most common pattern we see microscopically. Clinically, these people are called as pink puffers, because when these people are breathing, they tend to inspire easily. Their oxygen concentration is going to be normal, but since this alveoli wall is being destroyed, there will be collapse of the alveoli and they will not be able to expire properly. So there will be expiration defect and they'll find it difficult. So there will be a gap during their breathing. So this gap will be present, and during the time the patients will appear pink in color. So during their breathing, they appear pink in color, and that is why they were given this name, pink puffers. So blue bloaters by chronic bronchitis patients, while emphysema is pink puffers. And since this destruction of the alveoli wall is there, it is going to result in the barrel shaped chest. That is a very wide open kind of a chest. And complications is formation of bulla. So when this wall of the alveoli is being very thin, it is being destroyed, right? So the elastin is being lost. So the wall of the alveoli become very thin, and this can result in the dilatation of the alveoli also, that will form bulla formations. So these bulla can also rupture, and it can also undergo secondary infection and cause lots of trouble. So next we'll see about the next obstructive lung disease, which is bronchial asthma. So bronchial asthma is a reversible condition wherein there will be bronchospasm. So a reversible bronchospasm will be happening due to hyperreactivity of the smooth muscles, and also there will be mucus hypersecretion. So this is the classical definition of bronchial asthma. We have two types of bronchial asthma, which is atopic associated and non-atopic. So atopic associated is the one in which the patients will have a family history. So typically it will be a young kid whose family members might also have a history of allergic asthma. So usually what happens is it is a type 1 hypersensitivity reaction. So they'll have increased levels of IgE in their body. So they'll be allergic to some substance, and that will trigger this hypersensitivity reaction and bronchospasm. So when mast cells which are being coated with this IgE, when they come into contact with the allergen again, that is a second X response, this mast cells will degranulate, and that will result in the immediate mediators to be released, causing bronchospasm. So the main mediator was the histamine. So histamine, we have already seen that it is going to cause bronchospasm. So in non-atopic conditions, like it is also called as intrinsic asthma. So here the patients will be adults, and it is not going to be associated with atopy. So usual history they'll give for this will be a patient who was playing outside in winter, or doing exercise, some kind of exercise history or cold exposure history can be given, or even drug intake like NSAIDs can be given along with viral infections. So these people will be classically adults, and they'll not have any family history of asthma in them. And here the IgE levels will be normal. Okay. So the genetics of this asthma is very important. They can be asked in MCQ questions. So recently they have been asking this. So atopy associated asthma is going to have a relation with chromosome 5q. So atopy related gene will be there in chromosome 5q. Other than that, we can have interleukin 13 gene polymorphism, then ADAM 33 gene polymorphism, and increased YKL40 levels. This YKL40 levels are having a correlation with the severity of the disease. So these four genetics are important in respect to asthma. So I had already mentioned about the pathogenesis of type 1 hypersensitivity again. So this I mentioned, right? So IgE coated mast cells, when they get re-exposed to the allergen, they will result in the degranulation of the mast cells. So degranulated histamine is going to cause the bronchospasm, mucus hypersecretion, and leukocyte recruitment. Other interleukins will also be released, and this will cause the leukocyte recruitment. In the next phase, that is a late phase of asthma, what happens is it is going to be because of eosinophils. So eosinophils, it will result in the airway remodeling. So what happens in the airway is when this when the cycle of repeated insults happen, the smooth muscles and the mucus glands present in the bronchi will undergo hypertrophy and hyperplasia. Okay, so smooth muscle and mucus gland hypertrophy and hyperplasia is caused by the late phase, and that is actually because of the eosinophils and their mediators. So if they ask early phase of hypersensitivity, it is going to be because of mast cell. Same goes for asthma. If they ask for the late phase of hypersensitivity or asthma, it is going to be eosinophils. So there are certain image-based questions related to asthma. So the first picture, all of these pictures are cytology related. So the first picture is a cytology picture of Crayola bodies. So Crayola bodies are nothing but these are clusters of these bronchial epithelial cells only. So they are being expectorated in the sputum, and these are forming the Crayola bodies. The second image, can you appreciate that it is all forming some spiral kind of arrangement? So these are nothing but the mucus hypersecretion which form the mucus plugs, and it is going to take the shape of the trachea while during it is expectorated. So this spiral kind of appearance is called as Kirschmann's spirals, which are nothing but the mucus plugs only. A third image is that of the Charcot-Leyden crystals. These are needle-shaped crystals which are going to be composed of galactin 10. So what is galactin 10? It is one of the eosinophilic protons. So it is released from the eosinophils only, this galactin 10, and that is responsible for the formation of Charcot-Leyden crystals. So we are done with bronchial asthma also. So let's move on to the last chronic obstructive lung disease, which is bronchiectasis. Bronchiectasis is ectasis anywhere, it means it is going to be dilatation. So bronchiectasis means there is going to be dilatation of the bronchus. So this dilatation is permanent. Permanent dilatation of the bronchi and bronchioles is called as bronchiectasis. And here, the major pathogenesis here involved will be, there will be an obstruction initially in the bronchus. And when this obstruction is there, suppose there is an obstruction over here, the part which was distal to it will start accumulating the secretions. Their secretions cannot drain. So this part will be secreting the mucus and secretions. So it will all get accumulated. Firstly, when there is any secretion which is getting accumulated without drainage, it can be a fertile soil for infections. So first thing to remember is that. Secondly, the air cannot go past this, right? So this part, distal part, is going to be collapsed. So this collapsed part in which there is accumulation of the secretion is going to attract infection. So the infections, especially necrotizing infections, are the most common cause of this bronchiectasis. Other than that, we can also have various genetic causes. So starting with cartilaginous syndrome. So cartilaginous syndrome, it is an autosomal recessive condition wherein a defect is there in a dynein protein. So this dynein protein is one of the proteins seen in the cilia. So we have already seen bronchial epithelium is going to be bronchial and bronchioles are going to be lined by ciliated columnar epithelium. When there is defect in this dynein, the cilia will be affected, and without the ciliary motility, the proper ciliary motility, whatever secretions or infective particles are there, it cannot be cleared easily. So the secretions are going to stay there only, and the infections will be coming and they'll also stay there only. So this kind of a double attack is going to be there. And also there is this cartilaginous syndrome, it is a classical triad. So the first part of it will be the bronchiectasis. Secondly, sinusitis. Sinus, again, in the upper respiratory tract, we need the cilia to clear out the debris or any allergens which are coming. So without that, there will be inflammation of the upper respiratory tract and sinusitis. And third thing will be situs inversus. So during embryogenesis, for the cells to move, you need ciliary movement, which is caused by this dynein protein. Since dynein is defective, the cell motility will be affected and proper embryogenesis cannot happen. So situs inversus is just that the right side organs are not present on the right side and left side organs are not present on the left side. So their site is inverse. So heart will, rather than being present on the left side, is going to be present on the right side. So such things will be there in cartilaginous syndrome. And since ciliary motility is defective over here, it can also result in infertility because sperms cannot move without the ciliary motion. So sperm motility is not there, so it will result in male infertility. So the other causes of obstruction. So obstruction was the major part with which this bronchiectasis started, right? So what are the causes of this obstruction? Any foreign body causing obstruction, or any mucus which is forming a plug and not letting it go. So that can also form an obstruction, especially in cystic fibrosis disease. So cystic fibrosis is a disease wherein we have CFTR mutation, right? So mucus production is there, and this mucus can also form obstruction, or even any tumors. Tumors can also obstruct the airway. So most commonly this bronchiectasis is going to be seen in the left lower lobe, and here again, since it is associated with infection, the patient is going to have lots of purulent sputum production. So classical infection was necrotizing infection, right? So purulent kind of production of sputum will be present, and the patient can also present with dyspnea. So the sputum production will be more during early mornings or when the patient shifts position. Okay, so during that time also there will be copious sputum production. And a very important thing in comparison with chronic bronchitis is bronchiectasis is not associated with cancer, but it is going to be associated with amyloidosis. Okay, so now we had seen about the chronic obstructive lung diseases.